vamos a empezar esta mesa de encuentro con el experto. Vamos a hacer preguntas tanto científicas como estamos abiertos a todo, totalmente. Entonces, bueno, hablaba yo con Javier, no vamos a presentar los ponentes porque ya los conocéis a todos, después de esta larga jornada. Ya nos vamos a relajar, ya hoy bastante tenemos ya por hoy, tenemos esta sesión y luego el Festival de la Vacuna con nuestros amigos y luego el mago y luego nuestro cóctel, como siempre, ¿no? O sea que vamos a relajarnos ya un poquito. Y yo quería empezar preguntando a Javier, el otro día hablábamos, ¿tú por qué estudiaste medicina? ¿Por qué te gustó la medicina y por qué te gustaron las vacunas?
Bueno, medicina estudié porque mi madre era pediatra y entonces he mamado la pediatría desde siempre y acabé siendo pediatra. Pero las vacunas sí que es interesante. Yo en la vida me hubiera imaginado. Yo hice la residencia de neonatología, estuve en la Universidad de Oxford haciendo neonatología y cuando vine a España cambié. Y os voy a contar el porqué, os voy a contar un cuento. Si me pones las diapositivas. Bueno, pues mirad, yo cuando volví del Reino Unido acabé la residencia y entonces estuve trabajando en un hospital, hacía neonatología y hacía guardias en puertas. Y un día me llaman de puertas porque había un niño que tenía un absceso frío en un glúteo, tenía un bulto. Yo acababa de aprobar las oposiciones a atención primaria, 15 días antes, y el tema de vacunas ni me lo había estudiado. Digo, de lo que me acuerde de la carrera es suficiente. Entonces solo teníamos la DTP y la triple vírica. Y entonces, claro, el niño, yo le preguntaba a la mamá y no le habían puesto ninguna inyección, excepto las vacunas que se ponían en el culo. Total, me pasé esa noche estudiando, estudié culo Jiménez. Y lo que aprendí esa noche es que las vacunas, sobre todo la DTP en aquel momento, si se ponía subcutánea, producía abscesos fríos, que nunca nos lo habían dicho en clase. Total, que acabo de aprobar las oposiciones, 2 meses después estaba en atención primaria y el primer día veo que todas las enfermeras estaban vacunando en el culito, en el glúteo. No os metáis conmigo de machismo, porque esto lo dibujó un dibujante de cómic, no yo. Es que a veces me lo han dicho. Es que eres machista. Bueno, pues entonces lo que hicimos fue, con un grupo de pediatras que habíamos entrado con esa oposición, pues fue mirar a ver qué pautas se hacían de vacunación. Y entonces vimos que en todos los centros de vacunación de Valencia se pinchaba en el culo. Y luego que había un desorden extraordinario con la profilaxis antitérmica, en el que unos daban paracetamol, otros daban ibuprofeno, otros no daban nada, otros recomendaban, es decir, un desastre total. Con lo cual decidimos, este grupo de pediatras recién incorporados a la atención primaria, en estudiar el problema y hacer un estudio para resolver nuestras dudas. Y entonces tardamos 1 año y medio en diseñar un ensayo clínico para ver cómo funcionaba el ibuprofeno como profilaxis. 1 año y medio. En aquel momento en España no sabía nadie hacer ensayos clínicos. Yo me acuerdo que un día hablando con uno de metodología dice, tendrás que calcular el tamaño muestral. Y dije, ¿y eso qué es? O sea, que fue un aprendizaje rapidísimo, pero con un objetivo claro. Total, que conseguimos un poco de dinero, por lo menos que nos pagaran la medicación. Hicimos el ensayo clínico, fue la primera publicación que hicimos en una revista internacional desde la atención primaria, y todos los que firmamos eran de atención primaria, pero sobre todo lo que nos llamó la atención es cómo después de ese ensayo clínico que habíamos promovido nosotros porque teníamos dudas sobre la vacuna, el gran beneficiado pasaron a ser nuestros niños porque les pinchamos como correspondía y dejamos de utilizar medicación que no servía para nada. Y a raíz de ahí, ya después de eso, pues ya este grupo de investigación, que luego fue el germen del VIVA, del Instituto de Vacunas de Valencia, pues ya empezamos a hacer montones de estudios y nos ha llevado pues donde estamos ahora.
Si os parece, vamos a ir alternando preguntas de la audiencia. Podéis hacer preguntas científicas o de lo que queráis. ¿Alguien quiere hacer alguna pregunta? No todos los días se tiene este panel aquí de expertos. ¿Queréis hacer una pregunta?
Yo cuando conocí a Dagan, hace ya años, él era la peste del laboratorio del ¿cómo se llama? El antibiótico de los 3 días.
La citromicina.
La citromicina. Me acuerdo siempre peleando en el ESPID con la citromicina. Entonces estabas totalmente metido en el mundo del antibiótico. ¿Cómo de repente pasaste al mundo de la vacuna y te hiciste neumococólogo?
Oh. So you are like, look, you are like all my friends, like where's Federico? You only think that what you see is the truth. You don't know that there's something behind it, inside. So I will not tell you when I'm 70, almost 77 years old, so I have more time to tell stories than you. But this, in fact, was the hidden thing about my start of vaccine studies. So I did my fellowship, when I went to my fellowship, I didn't even know. I thought the Americans were so genius. We are so retarded in the Middle East. And just let me get to some fellowship. And I found myself in Rochester, New York for many reasons. And I don't know if you know, but Rochester, New York was the place, the chair of pediatrics was David Smith. This was the place where the first CRIM conjugate vaccine, the hip titer, was invented in a small startup that was called Praxis, just near my dorms where I was sleeping. And I came to Rochester. I was young, of course, relatively young. I was like 30-something. I had a son, one child at the time, 18 months old. And I meet on the second day a strange guy named Porter Anderson, who is actually one of the inventors of the vaccine. Very, very genius, but strange. And he comes and tells me, Ron, you know about Haemophilus influenza? I said, yes. You know the difference, conjugate, not conjugate? Yes, I read, I know. That was 82, before, he said, we are working on a vaccine that is a conjugated vaccine. And we have some prototypes, and we prepare it by cyanide and other things like that, to get it conjugated. I had it in my freezers. We already gave it to 20 people, so don't be afraid. I would like to give it to you and to your son. And I'm like, what? Cyanide? And he said, no, cyanide goes away very fast. And I don't worry, I gave it to 20 people. This was different times for GCP, okay? I said, fine. So I got one, my son got one, we got swollen arm, fever, and we had a lot of antibodies. So this was my first encounter with the investigational vaccine, 82. But then I spent all my 3 years of fellowship without being part of this group because they were too much into it. I wanted to start something else. I did some enteroviruses and things. Then I came to Israel, and I decided to look at the next vaccine in '85. And the next vaccine, at that time, conjugates started to be studied, and I wanted to look at pneumococcal vaccines. But who gave me money for pneumococcal vaccines? I mean, it's like, So I said, okay, I need to do epidemiology because everybody does studies, but I need to know pneumococcus epidemiology, so eventually I will be able to see what happens. So how do you get the money? There was a study from the States, from Harvard actually, Boston, about, not for Boston University, about double tap and looking at the microbiology and what antibiotics did for. And then came cefuroxime, and I went to Glaxo, and I said I can look at the activity of cefuroxime, and they gave me some peanuts because I was nothing. And I did some studies which were interesting. And then I found out that I can make money when I test antibiotics for otitis, and with that money I can start to do epidemiological studies. So quite fast, the PK/PD people understood that I'm a treasure because they can look at eradication in the middle ear rather than just look red or not red ear. So I started to get money to do from various antibiotic companies. And so GSK was giving me money to do Augmentin and others. And then came Pfizer and asked if I want to do some azithromycin study. And yes, I said yes. I thought it was a great drug. And of course, I found out that azithromycin doesn't do anything for extracellular bugs and doesn't do anything for eradication of bacteria from the middle ear. And boom, in one day, I became the friend of GSK and the enemy of Pfizer because I was speaking against azithromycin for otitis media. I became so famous. Everybody gave me the money, and this is why I have the fantastic epidemiological studies. And I was waiting until people start to ask me, are you interested to do something with pneumococcal conjugate vaccines? And that's how I got it. So basically, I all the time was like these freedom workers. I was putting the field ready for pneumococcal, so you missed it.
Okay. Maria, I have a question for you. Forget about COVID. Forget it.
No COVID.
No COVID. Why did you decide to become an epidemiologist and to work for the World Health Organization?
Oh. I was one of those students who always loved science and math. And I had a wonderful high school teacher who taught AP biology, Mr. Goodfriend, who I adored. I still do. And he had this infectious way he taught, forgive the pun. But I always was interested in science. And when I went to college at Cornell University, I worked with a professor, Eloy Rodriguez, who studied medicinal plants and ethnobotany and zoo pharmacognosy. And in the summer, I spent my summers doing research in Costa Rica, in Venezuela, in Mexico, and I still don't speak Spanish, I'm sorry to say, looking at medicinal plants and working with medicine men, medicine women, and how they used the plants around them to treat disease. And I became fascinated with disease and viruses and why were these viruses causing disease in some and not others. And that evolution and that synergistic relationship in some species and not in others, I found quite fascinating. I took one epidemiology course at Cornell, which was the most boring course I've ever taken in my whole life. But I really became fascinated with science and disease. I did a master's at Stanford, where I studied cancer. I was doing some research projects in cancer, and I had another professor, Paul Bash, who sadly has passed away, who did a course with me, who said, let's pick some papers. You read a paper, we discuss it together. And it was just this nature in which you looked at science and you looked at the study of science. But I became aware of WHO, I don't remember when I became aware of WHO. Growing up in the US, I knew of US CDC, but I didn't know really of the United Nations or the World Health Organization, sadly. But once I learned of it, I was obsessed. And I wanted anything I could do to work with WHO. I wanted to be part of that group. I wanted to be part of that global community of people who were tackling these diseases, and I wanted to get in any way that I could. I did my PhD on avian influenza in Cambodia, and in Cambodia I learned everything there is to know about outbreak investigation, about One Health, about collaborative research, about community engagement, about prevention, about sample collect, everything. And I was completely hooked on emergency response, outbreaks, markets, anything that I could learn. And through there, learn more about WHO. And I've had various positions, but I was offered a contract with WHO, a $1 contract, which I had for 8 years. And I was paid by someone else, but I just wanted in. I wanted to be involved, and I got involved with MERS in 2012, and for 10 years worked with WHO to develop the guidance, to work with international researchers, and I went on a lot of missions. So I spent a lot of time in the Middle East in outbreaks, in Asia on outbreaks, in Africa on outbreaks, and this is where you see ministries at their worst, their absolute worst. You don't know where you are in the outbreak. You don't know if cases are going up or you're just really just starting to understand that the outbreak is coming under control. And just that ability to support and help and understand and bring that outbreak under, I'm gonna just totally love what I do. I don't love it every day, as I'm sure all of you can appreciate, but this area of work that we work in, I think we're quite lucky. Because I also think during the pandemic, a lot of people thought, well, I really don't like my job. I really don't like my field, but I actually feel quite lucky. And then I just, got a job at WHO as the MERS focal point. And when you have an event that takes place, an outbreak or something, we at WHO use an emergency response framework, which forms incident management teams. And whatever that event is, there is someone who takes on the role of a health operations and technical lead. Because I was the MERS focal point, I took on that role because we immediately thought it was a coronavirus, given that all of these other pathogens had been ruled out. And I guess the rest is history, but we didn't anticipate anything like this. So I was hooked as soon as I learned about it, and I've drunk the Kool-Aid. I'm in it. It's in the agency. It's the only organization that has the mandate to protect the world, to keep the world safe. There's a lot of organizations that do that, but we are a member state organization and we serve the people. And so I'm hooked.
I would like to ask the whole panel, do you like and have time to listen to podcasts? And in that case, which one would you recommend?
Ooh.
No podcast.
No podcast.
We do a lot of podcasts in my family, but a lot of them right now are self-help and mental health ones, because not to make light of this, but the last 4 years for my family have been incredibly difficult, and I think for the whole world. So we're listening to a lot of these about relationships, about families, about family dynamics, about figuring out how to navigate as we go through. So there's a lot of those right now. But there's a lot of good podcasts that are out there.
I can tell you that when you look at my schedule, I guess schedule of everyone that is sitting here, I mean, if we are not busy, you don't want us here, right? Yes. So when you look at my schedule, I have to interact with so many people, especially in the last years, where the little bit that you can breathe is filled with Zooms, because the Zooms come for the vacuum between things, and you listen to people talking all the day, or you talk, or both, at the same time even sometimes. So I do my walking 1 hour, 15 minutes every evening, and then I have time to listen. I don't want to hear words, no words. I put either classical music or jazz, and I go for 1 hour and 15 minutes, and I think this is an issue of preference, okay? So the podcasts, I know I miss a lot. I also don't have much time to read. I miss this because, we are like a young couple, me and my wife, because we are older, everybody's out in the evening. I mean, I've been there out. My wife has been there out. We need to be together. How the people at my age spend the time together? They don't sit and read each one, We watch Netflix, we watch TV. So I saw stupid film, but at least I can hold my wife and, and if a podcast, what podcast will be good for what? So I admit I don't listen to podcasts. Yesterday you talked to me about podcasts. And I said, I'm going to start too. But I woke up this morning and said, no.
Okay. Inci.
I may be the most boring person in this group. I don't miss ACIP meetings. That's my podcast. And I am with you. Like, I'm in front of the screen all day. That's my only social activity, I think. But ACIP meetings are good because you have the public as well. That part I really like. I was a member. I sat on ACIP, and there is a group from public who comes there, and they present on your face, and they question you about your work ethic, how industry paid for your presence and your ethics, everything. But you also have the science that is summarized with the CDC, by the CDC or the industry, which is a good discussion. I think it is very transparent. Again, boring, but I think I really enjoy ACIP meetings. Sorry.
Don't say we don't socialize. We have tea in your office. My office is here, her office is here, and we do socialize sometimes.
Okay.
I have a question for both of you. You are living in the States.
Yes, sir.
I mean, you speak English like an American, not the accent, okay? But taking the accent out, I'm a real American, both of you. You go to sleep. Which language do you dream?
En español.
That's a sad story. My kids, so I was born and raised in Turkey, and my second language is German. Then I went to US for my PhD. And my family speaks only English. I dream in English, unfortunately. I know it's a sad story.
Marietta?
En español. Claro. I sing Spanish too. I mean, I'm not a singer, but I pretend in my mind that I'm still at home as much as I can.
Interesting.
Marietta, y, tú que has llegado ya, cuando miras atrás, tu carrera como investigadora, has llegado a ser en la Universidad de Yale, tener ya una de las mejores universidades del mundo, la posición que tiene. Aquí hay mucha gente joven entre el público. Entre el público hay mucha gente joven. ¿Qué recomendación les darías tú para orientar su carrera orientada a las enfermedades infecciosas?
Como estudiantes de medicina o residentes, varias. Número uno, sigan sus pasiones. Eso yo creo que es la primera. Hay que seguir sus pasiones. Es una carrera bien difícil, hay muchos obstáculos y para llegar a donde quieres llegar tienes que seguir tus pasiones. Yo llegué a un momento en mi carrera y yo creo que yo siempre ando hablando de las veces que fallé más de que las veces que tuve éxito. Pero yo creo que eso es importante cuando los jóvenes lo escuchan. Yo llegué a un momento en el que yo vine de Puerto Rico a Yale y me volví lo que eran los demás en Yale. Yo era un 80-20, hacía 80% de research, 20% clínico, tenía grants del CDC, del NIH, publicaciones, era todo research. Y yo no me veía como norteamericano, pero era casi. Y llegó un momento en mi carrera que me volví bien infeliz porque había mucho honor en la ciencia, pero yo no me encontraba. Yo no encontraba a Marietta en lo que yo estaba haciendo, porque hacía muchas cosas que me traían mucha pasión. Trabajaba en la comunidad, desarrollé una clínica hispana, pero yo pensaba que estaba Yale en un lado y la comunidad en otro. Yo tenía un pie en un lado y otro pie en otro. Y era porque yo estaba tratando de ser el epítome del Yale Academic, ¿verdad? Y mi pasión estaba allí, pero no completa. Entonces, el advice número uno, sigue tus pasiones, y número dos, be true to yourself. Sé honesto contigo mismo. Y cuando no encuentras el camino, no iba a dejar la medicina porque ya estaba vieja cuando tuve este encontronazo, pero hubiese cambiado, no hubiese seguido haciendo lo que estaba haciendo. Y entonces volví a mis raíces. Me di cuenta que si yo me apasionaba mucho quién yo era, los latinos, que si realmente adoraba cuidar de mis pacientes migrantes, que ahí había academic pursuit, que ahí había un producto académico. Y entonces trabajé porque la institución entendiese que ser un académico de prestigio es más que grants, papers, etc. Y eso toma tiempo, pero esas serían mis recomendaciones. Sigue tus pasiones. Cuando no te encuentres, regresa a tu origen. Y número 3, ten muy buenas relaciones con tus familiares y con tus amigos, porque van a haber momentos en que necesitas esa alegría fuera del trabajo. Me siento en la oficina, le toco la puerta a Inci y le digo, vamos a sentarnos, vamos a hablar de cómo arreglarnos el pelo, de la ropa, etc.
Muchas gracias.
I hope my translator will not kill me, but when I hear this in translation, every time you say Yale, she said jail. And so it gets completely different meaning what you tell us.
Yes. So when
you went from wherever to jail.
So my father, I went to Yale as an undergraduate, and he was working at the time in Puerto Rico, but he had colleagues in the United States, and he would say, "My daughter, I am so proud of her. She's in jail." Y como lo pronuncia, jail es la cárcel. Y mi papá le decía a la gente, estoy tan orgullosa de Marietta, ella está en la cárcel. Y la gente lo miraba, so that resonates. Yeah.
Doctor Moraga.
Dos preguntas, una para Marietta y otra para el doctor Rondagan. Marietta, ¿cuál es tu vacuna preferida y por qué? Y al doctor Rondagan, en el ranking internacional de la vacunología española, ¿dónde la situaría usted?
Oh.
Debería decir que es la vacuna de la varicela o rotavirus, porque son pues, las que más estudié, aunque he estudiado yo creo que casi todas las vacunas. Pero tengo que aceptar que para mí la vacuna que más me impresiona, cuando yo era niña, si alguien me decía las vacunas van a prevenir cáncer, hubiese dicho pues no. Y realmente con BPH tenemos vacunas que previenen cáncer, no un tipo de cáncer, sino múltiples cánceres. O sea que no hay favoritos, igual que en hijos no hay favoritos, pero de la que más hablo tiende a ser BPH.
So I thought you were my friend. Now we have enough trouble in Israel. Now you want to put me into political trouble about how I rank Spain, whatever. So I will answer a little on the side, but then I will answer you something which is more serious. So first, in terms of if I have to travel to meetings and be in meetings on vaccinology, Spain is always up there with very few countries in the list, because somehow I find myself much more at ease and feel good with Spanish people. Add to this the Spanish food and the Spanish art and everything. So that's really always a treat, okay? But that is, when you want to avoid this. But I would tell you, I don't know if Spanish is not the #1 in the world in ranking, but that's not the question. I think that what I learned coming from Israel, who was, when I was a child, a developing country, and now is an OECD country, maybe the last of the OECD, but still OECD country, is that what I was taught and try to teach, that you judge people by the progress, not by where they are at a static moment. Now, if from the time I started to be interested in vaccines, and this was late 70s, beginning of 80s, if I have to rank countries by the progress they did in vaccination, in the number of pediatricians who know vaccine, who understand vaccine, to whom you can talk about vaccine as an audience, as a big thing, not individual here and there, I would put Spain in one of the upper, because in the last 35 years or so, the progress in Spain from really country that nobody wants to really, to one of the leading countries in Europe in studies and the way they do things and implement things, I think this is really very high.
Y una pregunta también por aquí. Sonia. Mónica.
Era una pregunta para Inci y se la voy a hacer en castellano. Que no estoy de acuerdo contigo que seas la más aburrida para nada, que me ha encantado tu exposición y que quería preguntarte que qué piensas en esto de que hay mucha más inmunosupresión de la que pensamos, de la disfunción inmune o disregulación inmune, porque yo creo que si el COVID nos enseñó algo, creo que va por ahí. Y luego, en relación con Marietta, como sois tan amigas y estáis al lado y así, en esto de la hesitance, ¿no? Lo de la reticencia vacunal, que yo creo que hay muchas familias, bueno, o por lo menos algunas, desde mi experiencia, que siempre cuentan problemas con las vacunas, ¿no? Como nos ha explicado Javier. Y entonces yo creo que puede estar o algo relacionado, o sea, no sé si me entiendes.
I will just confirm. So first, you're very kind. That part I got. That's wonderful. And the second part was about the vaccine hesitancy. And it is a problem. Even with the immunocompromised individuals, believe or not, I have patients who got organs, but I cannot give vaccines. And if you remember, during the initial phases of COVID-19, we, the transplant providers, were discussing whether it should be a mandate to get the COVID-19 vaccine to be eligible to get an organ. Because we thought that it is not ethical with the concerns about the vaccine supply on top of the organ supply. If you use that organ in someone who is not going to take care of that organ, that wouldn't be ethical, was our thinking. But I also agree that maybe there is a group that you will fail in terms of your communications, even though you give the right message, you are the right person to give that message, and you're giving the message through the right channels, you will still fail. But that's why medicine is a social human science. It is not, you cannot just Google and go. It is not engineering. Apologies if there's any biomedical engineers here. It's a human science. So you will fail. I fail, but I do succeed more than I fail because I vaccinate more patients of mine. But I also think that part of it is us. The ignorance, arrogance doesn't help. You cannot say, you're not getting the vaccine, you're anti-science. You're not getting the vaccine, you're not smart enough. That doesn't work. Unfortunately, in the US, apologies again, we are not doing very well. During the COVID-19, again, apologies one more time, we saw that the C for the CDC was not for communication. We gave out too many messages that were conflicting with each other. I worry that what we did during COVID-19 is hurting now what we are doing, so we need to gain that trust again. But it was not because we didn't want to do the best. You know, it was changing, we were learning, what we put out there was the best science that we had at that time. What we were missing was, I think, we should have been more humble by saying, this is all we know for today. You know, this is what we know, it may change. We didn't pass that message very well, so I think we hurt ourselves. And now it is coming back, unfortunately. I know the COVID-19 vaccination for the children is more sensitive topic here than what we had in US. And I had many discussions with my colleagues from Europe with mandates and pediatric vaccination with COVID-19. But unfortunately, I am having hard time to vaccinate my patients with the routine vaccines after COVID? I know this is not really the question that you asked, but this is what I have. Sorry.
Can I just comment on that? Because I wholeheartedly agree. I think what was done during COVID, and particularly on the communication side, first of all, it was just confusing.
Yeah.
And it was very, very difficult. But the messages that were coming out around the world were so different. And they were changing. And you're absolutely right. To be able to articulate the uncertainty is not an easy thing to do, even if you're trained in it. But there were so many people who overspoke and overpromised. Yeah. And with vaccines in the beginning, a lot of the message was, it will protect you. But we didn't say, around the world, we tried to say it will protect you against severe disease and death. Yeah. But everyone thought, if I get vaccinated, I won't get COVID, full stop. And I only need one and done. And that message really did not come across. But in so many different aspects, I think as the science was changing and as we were trying to communicate the science, and I lump all of us in that we didn't get it right. And I think it is harming us now. If you look at vaccination coverage for flu, if you look at vaccination coverage for COVID, for vaccine-preventable diseases, this is a tragedy that is unfolding in front of our eyes right now.
Exactly. I certainly agree. It is not easy. It is a real thing that we have to deal with. But again, we all agree that vaccines do not work if you do not vaccinate.
Right.
And if we do not vaccinate, no one will. And to be able to vaccinate, we have to communicate. We have to learn how to communicate with this idea. But you can't be arrogant. You have to be humble. And again, there will be failures. Again, if you can change the liver but cannot give the flu vaccine, I don't know what else I can do. But still, you're responsible. You have to try, I think.
Actually, I take it more like we live in the world in terms of vaccine. I was born in 1947, so I did not get any vaccine against smallpox, except smallpox and tuberculosis. There was no vaccine in Israel. I got pertussis at the age of 4 years, fortunately not at the age of 0, because then every 4 years I skipped the 0, but at 4 years I got pertussis, severe one. I got everything. I got measles, you name it, I got everything, okay? And I have antibodies for polio, everything. And okay. At that time, then vaccine came. This is the infancy of the vaccination period. Everybody in Israel got the vaccine because everybody gets vaccine. What is not a real question? I mean, they have vaccine are good for you, you get it. Then came more vaccine, and some diseases disappeared, and people started to ask the question, why do I get a swollen arm for a disease that I don't see, and all the stuff. That is the toddlerhood, where you start to have some temper tantrums. Then we actually showed disappearance of disease because, again, in front of our eyes, we took Haemophilus down. We took pneumococcus down. People actually for pneumococcus do not have anti-vaccine almost. It's the old stuff. Okay, so they see something. But meanwhile, they also start to read because they are now not infants, they are not toddlers, they are now teenagers, okay? So they are now adolescents, and adolescents have two things. First, they want to know, and second, they start to doubt whether their parents are so smart. So now we are in the adolescence. So they are coming to me like my children. And they know that everybody thinks I'm the smartest person in general, but I'm so stupid that it cannot even say. And my oldest son tells me when he was 16, Dad, you don't know, classical music is dead. You just don't realize it yet, okay? So all the stuff. So this is where we are now. And all of a sudden, the population sees that we not necessarily know what to say. We don't accept. And when we ask them difficult questions, they get angry, they get arrogant, And they say, well, I spend all my life doing it and you don't even know what it's forget about.
Yeah, yeah.
And that is, there is nothing more vexing than that.
Yeah.
And then come the COVID, and in Israel it was even worse than anybody else. You could at least say, they did it in Israel and nothing happened, but we were the first to do everything. And we told them things, and most of the time we were right, but nobody remembered that when you were wrong. And after 5 days we come and say, well, we say, don't give it to pregnant women. And then we say, you may give it to pregnant women. Then you say, give it to pregnant women now, because it's dangerous. Okay? And now we say, and then we say, give it to children. Children will be actually the one that do it. No, you cannot eradicate it with other children. And then, well, where is the bad thing about children? And if you look at the calculation, how many children do you have to vaccinate in order to prevent one case? I'm not sure. What did you tell me all those stories? And I think that we have to understand, if you go with this, we have to talk to a child psychologist, not to a communicator, and teach us how to talk to adolescents, because this is the period. And I don't think that anybody ever came and looked at this way. Like, we have now to work the vaccines by a collaboration.
Yeah.
So we don't know everything, but we have some data. And maybe a vaccine will be more slow to get in, but it's sometimes better than to push it. And I have a daughter that doesn't vaccinate because I know everything. And she says that in the brain is okay, but my heart tells you don't know what you're telling me.
Yeah. I think this may be, I can't think of anything else. The more successful you are, the more you are harming your significance with the vaccines. What I'm trying to say is, like, we have been so successful with smallpox, polio. Nobody thinks that vaccination is necessary anymore because nobody has polio. Like, why would you get a polio vaccine if you don't see polio, right? It will protect you from something that you have never seen. Then, your risk assessment is so different. And I think for developed countries, this is also kind of the privilege and the luxury. You can be against vaccines because you're in a developed country. If you get, rotavirus diarrhea, you wouldn't die. You will come to the hospital, we will hydrate you, you will go home. But if you get rotavirus in Karachi, you will die. You will die from pertussis in Karachi, but you don't in New Haven. So, but again, I agree with you. We need to talk. We should accept this is a reality, and we don't have the luxury to get frustrated. It is not going to help, period.
Ok. Bueno, yo creo que vamos a intentar cumplir el horario. Muchas gracias. Yo creo que podríamos estar aquí toda la noche hablando. Ha sido un rato muy bonito para mí. Pienso que a veces hay que ver otras cosas más allá de los datos científicos. Espero que hayáis estado a gusto con nosotros aquí esta noche y espero que os podamos ver muchas veces por Almería, ya sea para participar o para visitarnos cuando queráis. Muchísimas gracias por abriros con vuestro corazón en esta mesa y muchísimas gracias a todos.
Thank you.
Tengo que hacer un aviso. Vamos a empezar ahora el Festival de las Vacunas con Pepe Serrano y Lucía. Por favor, los aparatos de traducción simultánea, dejadlos ya porque ya no va a haber más, ya no van a ser necesarios, ¿vale? Al final de la... Y empezamos con el Festival de las Vacunas, con la magia y luego nuestro momento de relajación con nuestro conjunto ya y a bailar y a pasarlo bien.